Good morning. Well, actually afternoon, we've just made it into afternoon, so good afternoon. And thank you for the different time change. Normally we do these at 1 o'clock, but we had to adjust our schedule to 12 because Dan is off being doctor after we've rinsed his brain with all of our questions. So thank you for that. And welcome to the Reverse Rett Bitesize. My name is Catherine Sim and I'm the operations manager at Reverse Rett. And I'm also a parent to Georgina, who has Rett syndrome, and she's 28. She's 29, actually. I've just lied about her age. So at Reverse Rett, and just because I'm not old enough to have a child of that age, at Reverse Rett, we believe knowledge is power. And as parents of children with rare diseases, we also know that the onus is on us to become the experts in our child's condition, so that we can effectively advocate for them and ensure that their health needs are addressed and that they are protected as much as possible from the inherent risks of the condition. So through these bite-sized sessions, we hope to share the up-to-date information with you and give you access to experts in the field who can help you fill in the gaps, enabling you to be as effective and as advocate, I can't speak today, as an effective and advocate as possible to your loved ones. So we do try to keep these as tight as we possibly can. Dan does have to go off and doctor at 1 o'clock, as we've already said. So we're going to get through it as quickly as we can because we've had a lot of questions. We will be recording today's session, so a copy will be emailed to you all afterwards so that you can listen to it in your own time as well. We do ask that everyone just very quickly put your cameras on so that we can ensure that everybody who's in the room is who they say they are. It's also very nice for us to see your beautiful faces, whatever you may be doing, eating, drinking, hopefully not driving, and that we just get a chance to just say hello to everybody. So I can see lovely Louise, my tent mate from Iceland a couple of years ago. I can see Neil, very serious face there, Neil. Lovely, thank you. I can see Julie from Rett UK, which is brilliant to have you here today, Julie. And hello to everybody. If I don't know you, I'm sure I will do before too long. So we're going to start today's session very quickly. Normally, our normal process would be that we would have somebody doing a presentation and we'd all get to look at slides and go and nod a lot. But today is very different because we have got questions for Dan that you've all put in. If you didn't get a chance to enter your question beforehand, we do have the chat option at the bottom of the screen. So if something comes to you whilst other questions have been asked, pop them in. If we have time, we will ask them. If not, then afterwards we will send them through to Dan and he can come back to us with the answers at a different time. Those of you that were in last month's Bite Size will know that Rachel was not able to attend and you had to listen to me drone on indefinitely. So I'm very delighted to say that Rachel is back with us today and I'm going to hand over to her now and be quiet.
Thanks, Catherine. Hello, everyone. It's my great pleasure to welcome today's speaker, who will need no introduction to most people in the UK Rett community. Dr. Dan Lumsden is consultant paediatric neurologist and adjunct clinical senior lecturer at the Evelina Children's Hospital in London, where he's worked since 2016. Dan is the clinical lead for the Complex Motor Disorder Service and the Rett Syndrome clinical lead, as well as trustee and secretary of the British Paediatric Neurology Association. Dan's special interests include movement disorders, Rett syndrome, neuromodulation, acute neurology, and motor disability. He's primary investigator for the Taysha Gene Therapy's Rett syndrome gene therapy clinical trial. As well as all this, Dan is also a great source of advice and information for us all at Reverse Rett. He's a champion of the Rett Registry UK and is a regular contributor to bite-sized sessions and to our annual LEAP conference. Dan is renowned in the Rett community for his clear yet empathetic manner and for his ability to interpret and convey even the most complex information to the community. And that's one of the reasons that for this session, we wanted to have Dr. Lumsden answer your questions. Because with a condition like Rett syndrome, there are so many of them. And with all the changes that are happening in the community, the questions are always evolving too. So we have quite a few questions already lined up, but this is interactive session. So we want you to think as you're going along. If you think of questions, do feel free to put them in the chat, as Catherine has already said, and we'll try and get through as many as we can. So we will get going. Welcome, Dr. Lumsden. We are really glad you're here. Thank you for giving us your time.
Well, no, thank you for the very, very kind introduction and the invitation to speak. It's lovely to see the questions that have already come through. I always say there's no such thing as a bad question. Unfortunately, there are bad answers, but I'll do my best to try and avoid those if I can.
Okay, well, I would like to start by asking you a question, just something that I'm interested to know about you. So you work with a lot of children and young people with different disorders. What's different about Rett syndrome, and what prompted your special interest in this condition? And are you glad you took it on?
So as with lots of things in a clinical and a medical career, this was good fortune and happenstance that the Rett clinic kind of fell in my lap, to be perfectly honest. So I had the pleasure and the privilege of working with Dr. Hilary Cass when she was president of the Royal College of Paediatrics and Child Health. And at the time, I chaired the trainee committee, and we worked very closely on a number of different projects and a lot of work over several years. And when Hilary was coming up to clinically retiring, she's obviously gone on to do many other things that people will be aware of. She was looking for someone to take on the Rett syndrome clinic. I was a consultant neurologist at that time, and I was seeing some of the young people in the clinic because of their movement problem. And so she'd asked me to take on the clinic. And as with any kind of NHS handover, you have a remarkably short period of time to get yourself up to speed before suddenly you're anointed as a specialist. And I always describe it as a little bit like learning how to ski jump. There's a massive sort of accelerating downhill when you realize all the things you don't know, and then this joyous sort of leap when you start to find your feet in the clinic there. I think that I say this and I genuinely mean it. My Rett syndrome clinic is one of the highlights of my working week. And there's just something special about the young people with this condition. I think there are some intellectual challenges, and that's important in your work there around, I think some of the things we'll talk around today about teasing out aspects of the phenotype. So what's a movement disorder, where there's a breathing problem, what's epilepsy, and how we can investigate that and come to the right diagnosis and then pick the right intervention. But I think what's so fascinating about the condition is that this is not a degenerative disorder. So lots of the young people I look after very sadly have had an injury to the brain for which there's not mechanisms to repair that injury in the context of the setting of cerebral palsy, or they're young people who have got progressive conditions where they're very sadly experiencing ongoing damage and injury to the brain. And that's not the case for Rett syndrome. What we have is this neurodevelopmental and neurological disorder, a brain which is not functioning as it should, but is intact in many ways. And it's that potential and that capacity to potentially be repaired or reactivated, as it were. And I think this is what's so exciting around the gene therapy and all the data we have from our mice model. Though I'll probably say several times today, we're not mice, so we need to be a little bit cautious of how we extrapolate there. But it's that potential to make a real phenotype shifting change in people's presentation over time. And it's really just a great community. And obviously, I'm going to say this when I'm invited to talk to the community, but it really does feel like a privilege to be part of this broader community of Rett syndrome. And when I've been up for the LEAP days, when I've attended the Rett UK days, it's actually quite overwhelming at times. I found myself a few times having to take myself sort of out of the room just to kind of collect my thoughts there, because it's such a lovely, warm and welcoming community. And it just continues to feel like it's a privilege to be part of it.
That's really nice. Thank you so much for saying that. One of the most frequent questions that we see, especially on the Rett syndrome family face group, is about these Rett episodes. And so I think we should start there with our question. So it's basically about episodes that are not captured as seizures on EEGs, but they look like seizures or are absences. What actually are they? Can you give us more information about that?
So I can give a partial answer, but this is an area where I do think we need to do more work as a clinical and research community. So we know that young people and adults with Rett syndrome are very prone to developing epilepsy. And epilepsy is a condition where there's abnormality of the firing of the neurons, the brain cells on the surface of the brain. And typically they start to fire together when they shouldn't, and then it causes what we see as a seizure. And depending upon how much of the brain and which parts of the brain are firing in that abnormal way, we see different types of seizures. So it can be generalized, these big events where there's a change in behavior and often jerking and shaking on both sides of the body, or it may be very focal if it's just one small part of the area there. And we get very focused on that because there is a concern that when a seizure goes on for a very long period of time, it potentially in and of itself can be damaging or harmful to the brain. And so I think we are drilled into us as clinicians to think about seizures, recognize seizures, and treat them promptly. And the way we're able to look into that is with our EEG recordings. So these electrodes on the surface of the scalp, they're picking up the electrical activity in the brain underlying that. And we know that there are almost always abnormalities in that activity in young people and adults with Rett syndrome, but there are certain patterns of activity that suggest that people are prone to seizures. And of course, if we're able to capture an event, we can see whether there's a change in that brainwave activity. And if there's a change in the brainwave activity, it lets us know that the event is a seizure. Now, there are lots and lots of other things that young people and adults with Rett syndrome do that look superficially like a seizure, but it isn't. And a bugbear of mine is that doctors are very good at saying, oh, this isn't a seizure. But the next bit should be, and this is what it is. Because actually saying what something isn't, it's just not very helpful. Because I think for families, my experience has been very reasonably, you want to understand why something's happening, what it is, what the implications of that might be, and is it something that should be treated? And if that's the case, how might it be treated? It's recognized, if you go back through the literature for decades now, this question of events that are not seizures. And I think it's slightly unfortunate, in my opinion, that this has been grouped together with what people call Rett episodes. And the problem is that's a shorthand for saying, well, it's something funny that young people and adults with Rett syndrome do, but it's not a seizure. But we're failing then to recognize that these are different events that we can look at in different ways. The type of events that can look like a seizure but aren't can be a primary breath holding, so a change in the breathing pattern and a pause in breathing. Of course, if your breathing pauses, your oxygen levels drop. If the oxygen levels drop, the brain sometimes doesn't like that, and so you might stiffen or you might shiver. You can have other what we call autonomic episodes, so changes in your heart rate, flushing, sweating, and things that look quite uncomfortable, with pupils dilating or pupils constricting there. There can be episodes of gastric problems, so reflux, discomfort from those kind of things that come and go intermittently there. And there are also episodes that I will recognize as what I would call paroxysmal movement disorders, because I like to try and sound clever when I'm talking about things. But really, paroxysmal just means it comes and goes unpredictably. And a movement disorder is a problem with movements that a young person can't control. And we think when we describe seizures as a problem with the activity on the outside of the brain, movement disorders are problems with the deeper parts of the brain, basal ganglia and thalami, these deep sort of structures that we see there. And there are certain patterns and pictures that we would recognize, and often videos are incredibly helpful for us to tease this out. But each of these different things has different potential implications, and we might want to treat in different ways. I think a big problem is if we don't tease these things out, if we don't separate them as different events, working out what's the best way to treat them is going to be very difficult, because there's not one magic bullet that's going to treat all of these Rett episodes. How we might treat breathing disturbance will be different to movement disorder, different to a more dysautonomic event, a panic attack. And so this is an area I think as a clinical community, to kind of come full circle on my question, I think we definitely need to be more attentive. And as families, I want to empower people to say, thank you for saying this is not a seizure, but what is it?
That's brilliant. Thank you so much. Now, somebody also has posted a question to say that you did talk about these episodes at the Rett UK conference in October, and you mentioned that research should happen. Is this something that you personally are keen to pursue? We know you're very busy with lots of other things.
A little bit of having my homework checked, but yeah. So this is a real interest for me, and I think actually, my I should declare my bias, so not conflict of interest, but I'm a neurologist, so I tend to have a focus on problems and issues and disorders of the brain. Of course, Rett syndrome, very important, is a multi-system disorder there. I've started to look into this with some colleagues. I am in the process of just about to write up a systematic review. So we've looked at all the literature that describes events that aren't seizures. And to cut to the chase, the conclusion of that's going to be, it's not very well described and we need to look into this more. And we're starting to collaborate with colleagues to look at how we can take existing data from telemetry recordings, where we've got that activity that tells us it's not a seizure, but then a video showing us what goes on, to try and then see if we can work out how we might classify and phenotype these different events there. One of the things that I think will be extremely helpful and a collaborative bit of work moving forward is to try and get more videos from families there. But we need a bit of work around how we fund that, of course, but more importantly, how we manage those videos and how acceptable that is to the Rett syndrome community. So this is, again, another added benefit of being welcomed into the community with these kind of sessions. I will come back to Reverse Rett and Rett UK about how we can make sure that any research we propose is feasible and appropriate and is acceptable to the community.
To be honest, I think that a lot of people would really welcome this, because people need clarification, and they also want to be able to take something in to the clinics and show the doctors that there are answers.
And I think a very large, if I think back maybe 5-10 years ago, lots of my consultations would end with, well, let's do a long EEG recording and try and get events. Nowadays, it's, can you get us a video? And the next day, videos get emailed or uploaded to various platforms that we have there. And it's really revolutionized how we work through things there. I think that's then very good at saying that's not an epileptic seizure. We still need that little bit of work then about agreeing what these other events are and how to treat.
Another seizure question, but this time related to puberty. So any advice on worsening frequency and severity apart from increasing dosage or changing meds, and how long can they last for?
So I think, unfortunately, for lots of young people who have epilepsy, regardless of whether it's due to Rett syndrome or other conditions, there can be periods of time during puberty where seizures become less well controlled and more difficult to manage. That's partly hormonally related, and I think certainly lots of families will recognize over time that there's certain points in the menstrual cycle when menstrual cycles get established that are better and worse for seizures there. But also there's still that ongoing maturation and development of the brain. So even without it being a hormonal issue, it's a period of time where things can emerge there. Often we do need to look at our anti-epileptic medication and make those changes there. But I think we always need to think around what are other potential triggers. So I never get very long in a talk before I start talking about constipation and the bowels. No, I've arrived there after 19 minutes today. But we know for lots of young people that if they've got gut discomfort, if they're constipated, if they're feeling unsettled from those kind of drivers, it can lower the threshold for seizures. So making sure we're getting on top of all of those secondary issues there. But children and young people who are not ambulant, who might be prone to having problems with their hips or their back, adolescence and that pubertal growth spurt is often a time where there's a quite rapid progression of some of those issues. And so pain and discomfort, unfortunately, can be a driver for that there. For some young people where there is clearly that link with the menstrual cycle, it's been our experience anecdotally that families have opted to look at kind of birth control treatments to kind of regularize the menstrual period. And again, I think that's something which can be potentially very, very helpful for young people, but it's a very personal and family dependent sort of decision to make that choice there.
Okay, we've just had one question just pop in, and I'm going to ask it now because it's relevant, but we've got a newly diagnosed family who've joined the call today. Welcome. And she's asked, how likely is it that seizures will develop? Is it something that happens to most children? And just wanted to know what does she need to look out for?
So the best data we have about the incidence of epilepsy in young people and adults with Rett syndrome comes from the North American prospective study there. That suggested that the incidence during lifetime was around 90% for young people with Rett syndrome. So at some point in the lifespan of young people and adults with Rett syndrome, 9 out of 10 will experience a period of epileptic seizures. For some young people, that's an early onset and is often quite refractory, so very difficult to treat. But actually, there are then young people who will develop seizures that are relatively easy to control, and some who will have a tendency to have seizures for a period of time that they can grow out of. So this is why we'll always say for any young person who develops seizures and we start on treatment, after 2 years of seizure freedom, we consider a trial coming off the medication to see if it was still necessary there. I think it's very difficult to say when the absolute kind of risk period has disappeared. I think there is a chance that young people with Rett syndrome and MECP2 mutations have got a chance, if they haven't developed seizures in childhood, of developing in adulthood. But my best guess, and I think most of us would agree this, the older people get, and children and then adults get, without developing seizures, the less likely it is to get that there. In terms of what to watch out for, so I think this is difficult because what I don't ever want to do is to create more worry and more concern. And the more you worry about whether a child's doing something unusual, the more you watch them and the more you start to convince yourself you're seeing lots of things. And as we said, there's lots of things that young people do with Rett syndrome that looks like a seizure that isn't. A lot of how I diagnose things is get young people to tell me what they're experiencing. And that's the cruelty of this condition, is that we're not able to do that. We can't get that account for that there. I think be aware, talk to clinicians if you're worried about these, what I call paroxysmal events, things coming and going. The reassurance I would give is that, going back to that point I made earlier about some seizures being damaging if they go on for long enough, those type of events are what we call generalized tonic-clonic seizures, and they're very clear in it, and there's never a question if they're happening. You will not miss if a young person's having those. There'll be the stiffening, the loss of consciousness, the collapsing if they're standing or slumping to the side, and then the rhythmic jerking of arms and legs there. So those kind of big, very worrying events that we want to treat very urgently, that there's a risk if they go undetected, they're not the kind of things that I think young people and our parents and other carers would miss there. But, the more you look, the more you'll worry about things. And I don't want to kind of create an additional concern when it's not needed.
This question is kind of ties into everything that we've been talking about the different kinds of episodes. But in terms of tremors, so do you think tremors in Rett syndrome are associated with epilepsy, or are they a different part of the movement disorder?
Yeah.
Are they something to worry about?
Yeah. So a tremor I would talk about as a shaking or an oscillatory movement. And I have to apologize, I get enormously nerdy when I start talking about movement disorders. And I joke, well, it's not really a joke, that I grew a beard, so I had something to stroke when I was pontificating on videos of movements to try and sound clever there. So shakiness and a tremulousness is incredibly common in young people with Rett syndrome, and it spills into what we call the ataxia. So that lack of coordination, the inability to perform smoothly coordinated activities, and the unbalance with walking there. That's felt to be more of a deep brain structure, so not kind of on the surface of the brain like seizures there. And so as a sign of an epilepsy, that change in activity on the surface of the brain, a tremulousness is actually quite unusual. Normally what we see is that we get the stiffening of the posturing. You can get a very fine sort of tremor around that, but usually it's jerks which are quite rhythmic and are quite discrete, and you can almost kind of clap out the rhythm when someone's doing those movements there. So we always have to be careful about saying never and always, because young people don't read the textbook and will love to catch us out. But usually a tremor would be a sign to me that it's not a seizure, it's more likely to be a movement disorder or a never problem.
It's really great to be sitting here and listening to somebody unpick all the different kinds of little movements and things that people with Rett syndrome have, or big movements that they have, and helping us understand how these fit together and how they can be affected by other underlying issues, such as the gastro issues that you've talked about. So thank you. This is really helpful. And this is another area that I think ties in to that as well, which is breath holding. So perhaps we could start by having you answer, why does breath holding occur in Rett syndrome, and then we can go on to if there's any medications that people can look into.
So problems with an awake breathing pattern, well, I think it's fascinating how unusual a breathing pattern can be. And the minute someone goes to sleep, it all kind of normalizes, or often normalizes there, but are a really common feature in young people with Rett syndrome. And they're one of the minor criteria that we would use to help us make that diagnosis there. There have been lots of attempts at trying to group young people into different patterns of abnormal breathing. And so people will sometimes talk about the hyperventilators or the breath holders or apneistic breathing or heavy breathing. And actually, it's been my experience that if you watch young people over time, even in the clinic room, they often vary between these different situations. And it's very difficult. Measuring that and quantifying that's really, really tough. And actually, this is one of the things we've talked about a lot with drug companies, with other clinicians, other experts, about a measure for a clinical trial, because it's a really clearly important thing, but how we actually measure it in a simple and practical way is extraordinarily challenging. Going back to the mice, but I've said your children and your young people aren't mice, but we are able to measure it much more clearly, the breathing patterns in the mice there. And what is very clear from those kind of models is that the main driver to these problems with breathing seems to be the brainstem, which we'd expect. That's the part of the brain at the bottom that controls all these basic functions. And it's particularly a group of nerve cells that use serotonin as their neurotransmitter. So neurotransmitters are the chemical messages that the cells in the brain use to speak to each other. And they're important for us to know about because we can target them with drugs there. So we know, or we think we know, that it's the serotonergic system that is the problem for the breathing pattern in young people with Rett syndrome. And this is why quite often the type of medications that we might try to use target those kind of systems there.
Can I just say, I think it's interesting that you've been able to explain that to us, because for many years, I used to take my daughter to the doctor, whichever kind of doctor it was, and she had lots of breathing irregularities and kind of cycles through them. And they've changed over time as well. But people often used to just say, oh yeah, this is just something that happens in Rett syndrome and it doesn't really seem to do them any harm. And they kind of seem to right themselves, if you see what I mean. And I'd say, well, what about the long-term effects? And they'd kind of just say, well, we don't have any information about that. And of course, now she's an adult and she's got mild type 2 respiratory disorder and is on respiratory failure and is on BiPAP. So they clearly do have a longer term impact. And I don't think anyone's denying that now, but I think from what I read in the community, sometimes the significance and the need to address these breathing irregularities isn't as clear as it should be.
Yeah, I think there's lots of factors to that. So I agree. It's difficult to know how much of a problem they cause, and because it's difficult to measure, but it's clear that they do cause problems. So, children can get locked into it. And if children and young people are just locked in an abnormal pattern of breathing, it's stopping them from engaging in the world around them. I always worry about, well, if you're feeding and suddenly there's a change in your breathing pattern, the risk of aspiration, you're not protecting your airway there. We know that, as I said before, if you hold your breath long enough and you drop your oxygen levels, the brain quite likes oxygen. And if you don't give it enough oxygen, you can trigger a seizure. So we see those kind of patterns there. And I think sometimes, and it's difficult to measure this, sometimes it does feel like it's uncomfortable. And sometimes it does feel like it's an unpleasant experience. And I always say, just because something's not potentially harmful, doesn't mean it's not important. It doesn't mean it might not need treatment there. Because it's so complex and because there's not any evidence-based treatments, I suspect this is a reason why people often, as doctors, might shy away from trying to treat it, because we tend to stick for the things we're comfortable with. So we know about epilepsy, we've got some drugs we know, we've got some trial evidence to support that are likely to work, and it feels comfortable. When we're looking at other patterns of disorders, it's a little bit more uncomfortable there. And also, I think breathing is a tricky thing because is a breathing disorder a problem for respiratory doctors or for neurology doctors? And so it kind of falls slightly between those two groups. And the reality, of course, is that it's both those groups there. But I think it's something we're recognizing more, but it's difficult to measure. And I suspect if we had a simple measure that we could apply and extract from every young person, it would become more prominent. Because if we can simplify it and kind of demonstrate very easily that impact and show how we can improve things, I think that's something that people would certainly focus on more.
Yeah, and it's also a mental health problem as well. I mean, I spend a lot of my day trying to breathe in the right manner so that I can calm myself down and different things. And a lot of people do that. And so if you've got somebody who's all day having their breathing disrupted, it stands to reason that they're then going to be even more anxious. And so it's
absolutely, yeah. And we know, so, and obviously Professor Santosh's EBAD, the emotional and behavioral autonomic dysregulation model, encompasses that there. But just on a simple level, we all have experienced where we feel anxious. And when we feel anxious, we suddenly become aware our heart's racing, and it's not nice. And because it's not nice, it makes you feel worse. which makes your heart race more, and we get into these cycles. And it's a similar thing, I think, as well when you're breathing. Or occasionally we'll catch ourselves when you get really sort of worried and concerned about something. You can catch yourself breathing a bit faster, and that awareness is uncomfortable. It also, if anybody's ever kind of hyperventilated for any reason, if you hyperventilate, your lungs do an incredibly good job of getting rid of carbon dioxide. And if your carbon dioxide levels get low in your bloodstream, you feel quite dizzy and quite kind of woozy there. So there's lots of reasons why I don't think this is pleasant, and lots of reasons why I think there are situations to try and think about how we might treat it there.
Thank you. Catherine, do you want to ask the next question, or?
So I just want to, again, I'm going to slip this one back in. Our newly diagnosed parent is probably sitting at home thinking, what the hell is going on? And she just wants to know, how often does breath holding issues occur?
So I think it's quite common, but it's a spectrum of severity. So I think if we look really hard at all of our young, usually ladies, but men as well with MECP2 mutations, if you watch them enough, you'll pick up a slightly abnormal breathing pattern. But I think it is a minority, thankfully, for whom it's really intrusive and problematic. The data from the natural history study in North America suggested that the breathing disturbance improves over time. So it doesn't entirely go away, but it did seem like into adolescence and then into adult life, it was less prominent. And very similar to hand stereotypies, where they seem to have that kind of course of improving slightly.
Thank you. Another question that comes up a lot, and it was something that I didn't understand the difference to, is the difference between classic Rett and atypical Rett. We've got a couple of questions relating to that. This question asker says, on girls being diagnosed with Zapella variant or a retained speech variant, how is that diagnosed through genetic labs, and who makes the diagnosis? What's the difference?
Yeah. Okay, so I think this is a situation where our ability to test genetics and get hold of genetic data has slightly outpaced our clinical thinking. So Rett syndrome has always been a what we'd call a clinical diagnosis. So you make the diagnosis on clinical criteria. And it's not a tick box exercise. That sounds very belittling to say that, but there's a list of things that a child or young person has to demonstrate, then some exclusion criteria that would rule it out there. And the criteria that were last established were in 2010. And 2010 was a long time ago in the world of modern medicine. So those criteria, with all respect to the people that contributed to them, I think all of us would recognize that they're out of date now. At that point, they talked about making a distinction between typical Rett syndrome and atypical Rett syndrome. So typical Rett syndrome are young people for whom there's been a period of essentially normal development. Then there's a regression, usually in the second year of life, with a loss of hand skills, a loss of acquired speech, the development of the characteristic midline stereotypies, and then a problem with walking. And if you have those four, and there's not a clear other explanation like a brain injury or something that terrible that's happened in that way, then by definition, you have typical Rett syndrome. And about 98% of young people who tick all those boxes will have a mutation in the MECP2 gene. Atypical Rett syndrome are young people for whom they don't have all of those boxes. They don't tick all of them. And so you need to have at least two of those boxes. And then there are a list of other supporting criteria like teeth grinding, like awake breathing disturbance. My observation that are some of those minor criteria, there's 11 of them in total, are very specific to Rett syndrome, and some of them aren't very specific to Rett syndrome. So you can score quite highly and not have features that I would say are very, very specific there. But if you have two and you have enough of the minor criteria, then you would be described as having atypical Rett syndrome. Or if you've got those four, but you've had very abnormal development beforehand, that would be counted as atypical Rett syndrome. About 75 to 80% of young people who've got atypical Rett syndrome will have a mutation in the MECP2 gene. And there's a lot of other genes that are also associated. And some of them are genes that relate to the pathways that MECP2 works through. Some of them are very different. And some of those young people who don't have MECP2 mutations, if you follow them up for long enough, after a while, they look like something different. The features emerge, and that term's probably not the best term to describe them. Now, that kind of binary sort of typical or atypical, anybody who spent any time looking at young people with Rett syndrome, and just go to the Leap Day or go to the Reverse Rett Day, it's very artificial. And really, there's clearly a spectrum of the more severely and then the less severely affected people and everything in between there. And with now access to our genetic testing, what's happening is in the past, you would have to think, oh, could that young person have Rett syndrome and then test for a MECP2 gene? Nowadays, everybody who's getting genetic testing, certainly in the UK, gets a panel or a whole genome. You're testing for hundreds of genes in one go. And so we're seeing young people who have got changes in those genes, in the MECP2 gene, who wouldn't have been picked up by clinicians locally as having Rett syndrome. Some of them, when you go through things really carefully, actually they tick all the boxes, but they're just very minorly affected compared to that picture in the clinician's mind about what Rett syndrome might look like, but it's on that spectrum. Others, they're very sort of slightly affected, and the classical we're seeing now is young people where they don't really have a picture of any regression, but they've had an autism spectrum diagnosis for a long time. And if you spend 2 hours in a room with them, they do breathe a bit oddly. So there's these little kind of features there. There's a Pella variant, is also termed the preserved speech variant. So this is a description for what I think I would call now just the milder end of the spectrum of Rett syndrome there. And so there are some criteria around it having a slightly later onset. So it's usually a little bit later, the regression. The regression's not quite so severe, and there's a more rapid progression to a period of improving skills there. But I would say that this is all a little kind of, these boxes are a little bit artificial nowadays. And I suspect the next time that we are revising as a community the definitions, we'll recognize that spectrum. Now, what's going to be interesting is that clinical trials have all been around children with typical Rett syndrome or adults with typical Rett syndrome. So this is going to be interesting how that kind of translates. Though it is worth noting that the only drug that has been licensed in any authority for Rett syndrome is trofinetide, and the FDA in America, they said for all young people with Rett syndrome MECP2 mutations. So they didn't make that distinction there. But I think the genetic landscape and our access to it helps us appreciate that there's a much broader spectrum. And I suspect some of these terms are going to evolve over time. I hope that, I suspect most people in the Rett community would agree with that. I think there are some people who are quite a bit more wedded to those terms, but we'll see what the next revision comes around to.
That's all obviously helpful in terms of making sure that people can have issues accurately diagnosed and then get the help that they need. But I think one of the difficulties with it is it gives people whose children have more of a typical Rett syndrome diagnosis and a false impression of what's possible for their children. And the next question brings us to, the next question is about what can be expected with an atypical child. So this person's asking if their fully mobile atypical child has no mobility problems now, would you expect decline as they get older? And I ask this knowing that it's really difficult to answer.
So this is something that I know Rachel and I have talked about a lot, and I'm now seeing lots of young people in clinic very early on, because that access to the genetic testing means that genetic diagnosis are confirmed more early on there. And everyone very reasonably, when their child's diagnosed at 2 or 3, what does the future hold? And that's a real challenge there. If we look at groups of children, there are some genetic changes that are associated with a more severe clinical picture, but actually even within that, there's a big range and variability. So I'm not a doctor that will prognosticate on the basis of their clinical picture there. For me, it feels like there's a big difference between those young people who never walk or who lose their walking very early, and those who are walking and walking confidently. And I think there are two groups where they tend to have a different picture and an evolution over time. A lot of the issues we see with what people have described as that stage 4 Rett syndrome, which certainly doesn't affect all young people by any means there, are accumulated problems with what we might term secondary neurodisability. And a lot of that is because of not walking. So very sadly, if you don't walk, your hips are much less prone to developing normally, more prone of developing subluxation, so slipping out of the joint there. Similar problems with the back, developing the scoliosis over time, and then developing all of those secondary problems, particularly when you get into adolescence, that then cause those other issues and those other health problems there. I think the young person who is entering into adolescence, who is ambulant, is someone who is very likely to continue to be ambulant. But I appreciate that's a long time to wait to see that kind of change there. And I think what we do need to think about for the community is how to stratify young people. So what are actual sensible groupings and sensible labels that help us predict what's going to happen in the future and prepare families and prepare services there? Because one of the joys and wonders of the condition is that it is such a spectrum, and I never know what's going to come through the door in the clinic room there. But one size fits all in terms of advice about what's going to happen from that child who's I see at 2 or 3 when they're 18 or 19, we don't know. But I think that's quite a clear distinction, that when you've maintained your ambulation, the longer you've maintained it, the more likely you are to do so.
Thank you. Catherine, I wonder if we can do the last 2 questions. One is about sodium valproate before we move on to the gene therapy.
Yes.
So I'll go ahead and ask that, and you can ask the next one. So if someone's been using sodium valproate, a teenager, and they've been using it fairly successfully for several years, and their neurologist is now saying they need to try other medications because of the potential risk of pregnancy, which we know is not something people want to think about. What can the family do if the neurologist is saying, they'll present this to panel and basically saying, we're happy with this current seizure medication, and we don't really want to experiment with anything else. If they go to a panel, it's usually a closed panel that's not open for family to make an input. So what's their ability to make an input to this?
Okay. So I was very sorry to hear this, Craig, because I don't underestimate how upsetting it must be to hear that. So sodium valproate is a really, really good drug at treating seizures. It has side effects, and one of the real big problems is that it is a cause of what we call teratogenicity, so a cause of birth defects if a mother is taking the drug while she's pregnant. And this has been recognized for decades now. And it is the doctor's fault that this is the situation we've ended in, because the problem is, despite lots of changes that the regulatory authorities have made around how we are meant to use and prescribe sodium valproate, doctors have not followed those guidances as well as we should as a community. And women are still becoming pregnant taking sodium valproate in an avoidable situation, and children are still being exposed to this risk when they're born there. So the rules that have changed over the last few years, and particularly changed last year, are increasingly strict and almost punitive in a way. They're not intended that way, but it feels that way at times, because we as doctors have not responded to the lighter guidance and changed our ways. So the big risk then is, with the guidance as it is it talks about this potential for childbearing, the potential to become sexually active, and that is not really recognizing the realities of the young people that I look after in most of my clinics there. The rules are different for children up to 10 to kind of 15, 16 and above there. But essentially, if somebody is in that kind of 15-year-old age group, if the risk of them becoming sexually active and potentially becoming pregnant is deemed to be very low, and there are 2 doctors who look after epilepsy who agree that it's a reasonable medication for them to be on, young people shouldn't be being taken off medications. So it shouldn't be the case. Now, what it does is create a bit more paperwork. It means that we have to be documenting discussions, there's forms to be signing, but children and young people still should be accessing sodium valproate if it's the right drug for them. The guidance much more, I think, should be interpreted as telling us to use other things earlier and only moving on to sodium valproate if we really need to, but an unintended consequence of genuinely good intention guidance from the MHRA about trying to protect children in the future has created for lots of families with children with significant disabilities this really awkward and uncomfortable situation, which clearly wasn't anybody's intention to do that. So I think this shouldn't stop young people with Rett syndrome from accessing sodium valproate. And I think if we are getting a signal from the community that that is happening, that's something which I need to take away to the BPNA and other organisations. So I need you guys to let me know if this is a problem on the shop floor, as it were.
Thank you.
Thank you. The other question that we had in, it was very late, so I'm going to have to read it because my brain to remember things is not so good nowadays. So what is the best approach when you're atypical child with Rett syndrome or even an MECP2 I can't do that.
Encephalopathy?
Thank you. Has seizures which have improved with the new med but are still multiple daily. Should we seek more EEGs despite being refused in hospital recently? What should the family do? It is a very personal question.
Yeah. So again, difficult to give very general advice for a very specific situation, but thinking about general issues. So first thing goes back to, are we all sure that events are seizures? So, unfortunately, we still see young people in our neurology clinics that are labeled as having medication refractory epilepsy. And the reason that they're not responding to medications is there's something else going on. So it's that kind of clinical clarity, making sure that we know the events. If we know the episodes are all seizures because we captured them before, or they're really clearly seizures from the video recordings there, it's probably not necessary to get extra EEG, but there might be circumstances where we would do. So in terms then of how we approach very generally seizures, so we normally would start to treat seizures or consider it after we've had 1 or 2 unprovoked events. And we know, just speaking very generally, that about 50% of adults and children who start having seizures, you'll get seizure freedom when you have the first medication you use. So as long as you're using roughly the right medication, and there's a choice really depending on whether you've got focal seizures or generalized seizures, but 50% of people will get seizure freedom on the first drug. If you need to use the second drug, then about 25% of young people and adults get seizure freedom. So that's really saying that 3/4 of adults and children who have got epilepsy get seizure freedom on 2 medications. If you don't get seizure freedom on 2 medications, the chances of achieving seizure freedom very unfortunately go down very dramatically. And so the choice of whether we're adding in other meds, it then starts to be around this balancing act about how intrusive and how problematic the seizures are compared to the side effects and the downside of medication. Now, when I started, it's very sad, and this was longer ago than I'm going to care to admit on a recorded sort of session there, but we were still seeing young people who were on 5 or 6 different anti-epileptic drugs for their epilepsy and had horrendous side effects from that. They couldn't swallow properly because of it. They were sleepy the whole time. Their gut wasn't working as it should do. So generally now, we start to get a bit uncomfortable with people on 3 or 4 medications, but sometimes that is necessary there. And it's that kind of balancing act between, as I say, if we're not going to get rid of the seizures, how much of a problem are they causing us for us to reduce there, and how much of the problem will for that there. In terms of seizure freedom with Rett syndrome, I still look after lots of people who do achieve it. So I think it's still possible with 1 or 2 medications for some young people with Rett syndrome to get seizure freedom. But as I said, just as with anybody, when you go above that, when you're on a 3rd or 4th, it's less about seizure freedom, but still potentially reducing it. And it's that risk benefit. And obviously the risks of absence events versus generalized seizures are very different. There is this concept that we need to acknowledge, the sudden unexplained death in epilepsy patients, the SUDEP. And this is a consideration that we know that having some seizures versus less seizures, it makes the risk a little bit higher there. But those kind of discussions are very personalized around the young person's circumstances and where things are at with them. But I think starting point is, are we actually sure these are seizures? And then just being realistic about what our aim is with the intervention. I'm a massive advocate for the ketogenic diet. And actually, if you look at the data, there's not very many kind of specific trials of the ketogenic diet for epilepsy in young people with Rett syndrome. But if you look at the trials of ketogenic diet and kind of secondary analysis of them, it does feel like actually Rett syndrome is a condition that seems to be, generally quite responsive to it. And I know, of course, there's challenges with limiting the diet, and there's always that concern about affecting GI issues. But I would say we shouldn't consider epilepsy inevitably in young people with Rett syndrome to be refractory. And so what's the point in treating? So we're not going to get on top of it. We need to be mindful that not everything's a seizure, but still a lot of it is a seizure. And just as for any other child, we think about the ketogenic diet or things like a vagal nerve stimulator, we should do as well. And I say child, I do apologize. I'm a pediatric neurologist, so my answers are often child sort of biased, but the same holds true for adults with the condition.
That's really good to hear. We don't have very long left, and I want to get to the heart of what people want to know about clinical trials. And obviously, people want to know when they're going to see public information about UK trials starting. Let's not speak to that right now. Let's focus on the question that we have, which is about, as we've been talking today about the different phenotypes in Rett syndrome, it'd be interesting to ask this question about what differences we're seeing in patients on the clinical trial who have a different presentation. So we know from the Taysha trial that some of the patients have been more well children and some of the patients have been more severely affected children. So can you speak a little bit about what's been seen in terms of outcomes in that very small group that we've seen so far?
So I'm going to give what's going to sound like an evasive answer, but it's just generally because there's not a lot of data that we can speak to at the moment. So I would say I actually don't know anything more in terms of the Neurogene or the Taysha outcomes over what's been put into the public domain and what's been publicized by the companies there. And my starting point has to be to just make sure everyone remembers that the trials that are underway now, these phase 1-2 trials, they've all been really focused on the safety, and it's less of an issue around the efficacy. So this is how clinical trials kind of work. When you start giving trials, drugs, you give them to small numbers of adults or young people with the condition to ensure that there's no obvious worrying safety signal. So that idea that is it actually safe to upscale and give it to larger young people, or larger numbers rather of young people and adults with the condition to understand the efficacy, how it might work. With that, it means that when you've got very small numbers and you've got that variety within those small numbers, from the more able to the less able young people, it's then very challenging to extrapolate from it. And I think another question, of course, is the things that I know are important to me, and I suspect important to you as parents and carers and family members of people who have Rett syndrome, are things like communication, things like hand use, things like improving gait. And these are all things that I would expect, if a Rett gene therapy is going to work, are going to take quite some time to emerge. Now, things like seizures, we might hope and expect them to reduce quite quickly, but functional gains and things that are going to be important in the longer term to families and to those young people, that children and young people have to learn those skills. So if it takes a normally developing child months and years to learn to walk, to use their hands, to speak and communicate, we've got to expect that it's going to take months, if not years, to see the full benefits and the impacts of the treatments that we're giving there. I will say there have been some signals that I've been very encouraged by. And when people are talking about increased hand use and improvements there, I think this continues to be really hopeful. But I don't think we're in a position now to know quite how much improvement we're going to see and quite how quick this will be. This is really going to be going on for both the companies to their next stages of their studies, which they'll describe as the pivotal trials. So now we know what's a dose that's safe to give, or seems to be largely safe to give. How can we actually measure how much impact that has? And I think for both companies, we're going to find out more details of how they propose to do that in the next few months. And then I suspect getting that clearer picture is going to take quite some time to come back.
And quickly, we'll just say as well that it looks like your part of this clinical trial is now going to be part of the second part of Taysha's trial. Is that's public information?
Yes, yeah. So Taysha have now stopped the recruitment temporarily for the trial because they're analysing the data from the phase, the part A, they called it. We need to be careful. Phase 1 and 2 have very specific meanings for clinical trials. So that's currently being discussed with the regulators. And I know the company are keen to share information as soon as they can, but they're not in a position to be able to do so yet.
Thank you.
So thank you so much. Very conscious of time. We've got 4 minutes. So I just wanted to close up the day. We do have other questions in the questions, and we will forward those to Dr. Lumsden. Thank you for everybody for coming. I have enjoyed this session. It's been one of my favourites since we started doing Bitesize, and I'm sure that you would agree. It's always great to be able to get straight into the man with all the knowledge.
You're very generous to say that, Karen.
I know, I'm just buttering you up for later when I ask you something else another time. So this has been recorded, as we've said, and it will be emailed out to everybody. We'll also put a link on our Bitesize YouTube channel. So remember to like and subscribe. We will be seeing Dan very soon in May at our Leap Weekend event. Last day of May, 31st of May through to the 1st of June. So if you haven't registered to come up and see the man in person, please do. It's a 2-day event. We've got a little dinner and dance because one thing we're very passionate about is that our loved ones with Rett syndrome should be able to access the same kind of life as anybody who does not have a disability. So come up, have a boogie, have some dinner, listen to some brilliant talks and learn some new things about Rett syndrome. But most importantly, come along and meet other people who are in the same boat or a similar boat to yourself. So that's the 31st of May to the 1st of June. Thank you, Dr. Lumsden, and I hope you have a brilliant clinic. And we look forward to seeing you all in our next Bitesize, which will be Dr. Shetty on, I want to say, the 20-something of April. Off the top of my head, I can't remember, but you'll be getting emails about it. So thank you all for your time and have a brilliant Thursday afternoon.
Thank you. Thank you so much.
Bye, guys.
Bye.
Thank you. Bye.
Thanks very much. Thank you.
You're welcome.